Okay, everybody, welcome to your chapter on psychiatric emergencies. While this lecture is fairly short, it's probably one of the more important lectures you're going to deal with in the field because, like it or not, psychiatric issues have a significant contributing factor to an overwhelming majority of the other call types that we run to on a regular basis. So, while I'm not going to get way too off into the weeds on this particular subject, I would like everybody to pay particular attention to it. And if any of this interests you at all, I would absolutely recommend that you take a course or 3 on some psychological issues. It's only going to benefit you in the long haul if you plan to stay in EMS for a considerable amount of time. So as the introduction says, AEMTs often deal with patients undergoing psychological or behavioral crisis. And the crisis can be the result of a medical condition, some kind of mental illness, mind-altering substances, or just day-to-day stress. And because everybody's different, these triggers or things that are going to create that particular crisis is going to be different in everybody. So some people are really adept at dealing with stress on a regular basis, and they may become chronically overstressed to a point where they kind of snap. Mind-altering substances that alter cognition or have an hallucination or other kind of similar effect can create these particular crises. And then mental illness is a significant contributing factor for a lot of other disease processes or lifestyle situations for a lot of patients. And then medical conditions can also have an alteration of the cognitive ability of your particular patient and may cause another crisis. So there are some myths and realities, and a reality here is that almost everybody experiences some kind of emotional crises at some point in their life. And that could be the loss of a loved one, the loss of a good friend, the loss of a particular living situation. I mean, there's just no end to the things that we consider significantly important and the things that we're actually going to allow to impact our day-to-day lives. The most common misconception is that if you feel depressed, if you feel bad for any more than 20, 30 minutes or a day, that there must be some kind of sickness to you. And a lot of people will keep from reaching out for help, whether that be an immediate assistance or some kind of emotional support system that would help them through that particular situation because of the stigma associated with mental health and depression. A lot of people are under the assumption that when we say anything about somebody who has some kind of mental health crisis, that we're specifically talking about the people with aberrant behavior who are often violent. The truth of the matter is that very few people, regardless of their mental health situation, are actually physically intending to do you harm. It's always something that you should keep in the back of your mind, but it's not something that you should approach people with because your body language is going to present itself before your verbal language, and people are going to read up on your cues. If you look intimidated or threatening, they're going to respond in kind, and those are the situations that you want to make sure that you don't create or foster. So some of the things to remember is that you, as an EMS provider, as the AEMT, are absolutely going to experience a higher volume of people that you interact with who have some kind of mental health situation. And this is just by the nature of the job. It's something that we're never going to get away from. And like it or not, again, a big contributing factor to a lot of other calls has some kind of psychological component to it. And so the sooner that you recognize that you're going to be exposed to this and these things are going to come through, the better you're going to be able to help mitigate those issues and get that person to the treatment that they actually need. So we're going to define behavioral emergencies. And by behavior, this is the physical manifestation of what you can see from your patient. Now, mostly what we're going to talk about is when these particular patients are not dealing with that particular amount of stress or overloading of stimulus in a positive or normal way, right? This is impeding their life or the way that they're going to interact with other human beings. What you can see of this is that a lot of times people react to stress in a positive way. We know other people or maybe ourselves, we can see that we thrive under certain amounts of pressure. And in other people, if this particular amount of stress or the inoculation of multiple stressing environments comes together at one point in time, they will crumble. And this is where that behavior pattern becomes what we call aberrant or abnormal. And it's not something that's very suitable to normal society or what we would consider a societal norm. And as we were just talking about, that behavioral crisis is any reaction to an event that interferes with the activities of daily living, or it becomes absolutely unacceptable to the patient, their loved ones that are around them, or the community at large. And now, while there are many different defining parameters on what's considered quote unquote normal, right? Society has a pact to behave or to interact in such a manner that we believe one another to be polite and non-threatening. And so when you get that particular patient who now is violating that code of conduct for a normal society, that becomes that behavioral emergency, regardless of whether or not that's violence or just inappropriate behavior. Now, while this slide says that if it lasts for at least a month, it's a matter of concern, that's really not the truth. In the crux of it, many behavioral crises will kind of just become very acutely obvious to friends and families. So when we're talking about something like lasting longer than a month or something along those lines, we're talking about somebody who's maybe not acutely depressed because of the loss of something or something that's become tragedy or tragic in their life, but it's that they're unable to recover. So at like the 30-day mark, we're looking at that and we're saying, you know, what's wrong with the coping mechanism that they have for that particular event, and why is it not giving them the expected outcome? So when we have a psychiatric emergency arise, the patient may show some agitation and they may become violent because they're just at that point where the stress response is too overloaded and they kind of go into that fight or flight situation. They may actually become a threat to themselves or other people. And again, this is one of those situations when you're looking at your patient and you're really having to dig down deep and figure out, are they cognitively able to actually have rational communication and understand the things that are going on, or are they quite literally repressed into that position to where they have become the fight or flight response, right? And so, for the lack of a better way to put it, are they in their lizard brain? Are they only able to react to certain stimuli, and instead of actually using logic as a function for decision making? So as this slide was prepared, this says that 1 in 5 Americans has some type of mental disorder. In reality, it seems to be that we're more and more aware of the different types of mental health problems, and we're becoming much better at determining whether or not these are presenting themselves with more and more subtle cues. I would say that while I don't have a hard and fast number for this, it's probably significantly more than just 20% of the population. Psychological or behavioral symptoms that result in impaired functioning can be caused by social, psychological, or genetic causes. They can have some kind of physical cause, chemicals, or biological disturbance. And all we're saying there is that there's many different ways to cause stress and to elicit the same response that we want from that, or the person, in your case, your patient's inability to cope with that stress, and then they're becoming an aberrant behavior to that. Some of the things that you need to know is that it's not your job as an AEMT to diagnose the underlying cause of a behavioral crisis. Your job is to become very aware of whether or not they are acting appropriately as to the norm, and if they're able to use good logic in their decision making. You should also be very aware that there are 2 basic categories of the diagnosis, and that's organic or functional causation. The organic causation is a temporary or permanent dysfunction of the brain caused by a disturbance in the physical or psychologic functioning of the brain tissue. And this is brought about by sudden illness, a severe head trauma that's left with a TBI or a traumatic brain injury, seizures, massive or chronic intoxication, or other diseases of the brain. You can also have the temporary altered mental status that comes from low blood glucose levels, hypoxia or the lack of oxygen, and then any kind of hypoperfusion to the brain, which would be the inadequate blood flow. Heat or cold can have a significant impact on our ability to have good, solid mentation or a very high degree of cognitive function. And that's particularly due to the body wanting to maintain that homeostasis. If you guys remember that we've got a core body temperature and we want our core organs to have that same temperature, right? That we're designed to be at 98 and some change, right? We consider 98.6 to be normal. If the brain becomes suddenly cooled or chilled, right, the cellular functions are not going to operate the same way that they would at a normal body temperature. This can also cause some kind of pathophysiology in somebody's behavior or their psychiatric situation. Now, as we move into the functional pathophysiology, this is etiology that can't be traced to an obvious change in the brain itself. And some of these examples are going to be depression. Right? There's not a structural change in the brain for depression. Anxiety conditions, there's not generally a structural change in anxiety. And then schizophrenia, which is still very misunderstood, does not really have any structural change. And what I'm saying by this isn't that we can't observe different regions of the brain with an EEG firing in these particular situations. That has actually been observed multiple times. It's actually fairly good science. The issue is that we cannot see this physically from the outside without having these particular machines set up with a willing patient. So rolling into your primary assessment, first and foremost, anytime that you're going to something that's a behavioral emergency, your scene safety is the most important thing. Now, all life comes with a risk, and we're always going to teach that you should have law enforcement there to kind of clear and make sure that your scene is safe. You never want to put yourself in harm's way because you feel like you're willing to take that risk. It's just not worth it. So have somebody that's there who's trained to deal with force on force and the restraint of somebody who may become violent. Often having a law enforcement officer on scene with you is enough to get people to behave in a particular manner. Because remember, all of society is in agreement on how we're going to interact with one another. And it's so long as the rules are understood, most people will comply with them. You walking in with the false assumption that people do not generally want to do you harm is only going to get you into a bad way at some point. So determine your safety and make sure that you are taking the necessary precautions to go home at the end of the shift. When you do come in and you make your initial assessment, your primary assessment, it's that across the room kind of assessment again. We've said this in previous lectures, and this is looking at the patient and trying to kind of gather some of the nonverbal cues as to how that particular person is responding to the environment and you. Is that patient's behavior normal given the circumstances? And remember to put this in context. All too often, when we do have law enforcement there just so that we can have that peace of mind for security reasons, it could put that particular patient into a state of escalation or anxiety. That person is an authority figure and they carry a weapon. So you're going to have to be able to kind of parse out the difference between normal everyday anxiety over a situation requiring law enforcement to be on scene with you versus somebody who's becoming escalated without or outside of normal rational thinking. Now, you always want to make sure that you're going to do your actual assessment, but we want to make sure that you're coming at this from a calm but very measured way. You're going to limit your touching. And very often when I'm on a particular call like this, I'm going to ask for permission to touch this patient. I'm going to explain that if we're allowed to just kind of get through the actual physical assessment, we can get to giving them their personal space back, because we just really want to make sure that there's not an apparent life threat hidden underneath clothing, because we were trying to stay away from actual physical contact. Again, a lot of these patients are not very welcoming to a lot of touching or close proximity. They're usually agitated, they have high levels of anxiety, but if you're very calm in the way that you do this and you are making sure that you're reading their nonverbal cues, you can have a relative amount of security in the ability to perform this assessment. And again, this should only just take you a couple of minutes to kind of get a real quick assessment, right? We're not doing the secondary assessment and touching and feeling and doing all these things right out of the gate. That's something that may come after you build a little bit of trust. Always kind of stay on your feet, right? Don't put yourself in a position where you're going to be in danger if that person now becomes unpredictable. That is something that's just simply not acceptable as a risk to you or your partner. Again, with these potentially violent patients, it's really just a very small number. And for the most part, if you've let law enforcement kind of go through this situation first, and they've declared that this scene is stabilized for you to come in and do your assessment, the likelihood of them becoming significantly violent, like randomly, is even less. So that's just another reason for you to always let law enforcement kind of be your partner with a different role. Now, you're going to try to do the best that you can to assess your level of danger, and that's by finding out historical parts of this person's history from friends or family or anybody that may know them before you start asking them questions. You're absolutely going to look at their nonverbal communication, and you're going to see, are they posturing? Are they getting ready to become physical? Do they look like they're about to move with sudden or quick or violent reactions? Always looking at their core, looking at their facial expressions and the way that they're looking. There's usually a tell for every action before it happens. Look at your scene. Is there things around the patient that could become potential weapons, or things that would give you clues as to why they are in their present state of mind? Lastly, let their vocal communication help finish out and give you the finer details of what the actual problem is for this particular event. Now, at the bottom of this slide, it says other factors such as low socioeconomic status, tattoos, and substance abuse. And this is where I'm going to kind of disagree with this particular part of the slide, right? Tattoos are a social construct, and they are either acceptable or unacceptable by generation or type of person. And don't let somebody's permanent artwork change your mind as far as what their behavior is. Just because somebody has tattoo work doesn't mean that they are any less of a productive citizen than you would be, or that they can't be trusted or shifty, right? The socioeconomic status, the only thing that's going to come into play on this is whether or not that particular person has the ability to get the medical help that they need. So just because somebody's poor doesn't necessarily make them prone to become violent or depressed or have some kind of other behavioral issue, right? Very often you will find that as you work longer in EMS, regardless of socioeconomic status, patients tend to have the same problems. This is just a human condition, and it has very little to do with the flow of money in and out of their hands. The only way that this actually works is if somebody is unable to actively seek out help and get the treatment that they need due to financial considerations. Now, substance abuse, this can actually be a bigger issue when we're looking at it. And if you see evidence of consistent or habitual drug use, a lot of these things can actually factor into the mental health or the well-being of your patient and may have some kind of contributing factor to their behavioral crisis today. Now, when we're dealing with a psych call, this is one of those situations where it's probably actually a little bit more beneficial for you to take your time. Again, this is mostly to do with the fact that you're trying to gain their trust, and you want that patient to trust that you will do no further harm to them. For them, Even something as simple as a BGL stick may be something that they're just unwilling to tolerate at that point in time because they don't trust that you're not trying to cause them physical harm with the emotional harm that they're already experiencing. So you also have to make sure that you understand where they may have gotten their treatment and what's the most appropriate facility to go to. Unfortunately, a lot of systems will use the ER as the dragnet or the catch-all for all of their patients. And this may not be the most appropriate thing. Thankfully, we're in the 2020 year, and there are huge initiatives on behavioral health, and things are changing, and we're trying to better utilize the resources to get these people the things that they're really needing. You could draw the same parallel with if somebody had a broken arm, you don't take them to a cancer center to get their arm set. In the same token, we don't want to take somebody who's having purely a behavioral crisis moment and dropping them off in the waiting room at a regular ER. That's really not appropriate for them. They're not going to get the care that they really need to have, which is one-on-one with a provider so that they can kind of mitigate the crisis that they're in. Leaving them in the waiting room is probably really not appropriate for a lot of them, and unfortunately there are still systems that just do not have the resources for that. And you're going to have to learn those resources so that you can provide the best care possible. More on history taking. So we want to investigate our chief complaint. So open-ended questions are really, really good. This is something where you want the patient to use their words to formulate things. You're going to try to use therapeutic interviewing, and again, we're not trying to invade their space. These persons are experiencing something that's really, again, an overwhelming amount of stress, and we don't want to contribute to it. And one of the last things that we should consider is that the patient will often find one person or the other. It may just be one person in the room that they're willing to talk to, and the rest of the people in the room are considered in agitation. Let one of the people who has that rapport with the patient be the one that does all of the history taking and the documentation. Now, even if they're a lesser license level, if they've established that ability to communicate, that's okay. Just let them take care of what they need to take care of and try to work around this with the patient. Try to use that partner that you have or the person who's established that trust, earn trust in you. Deeper into the history is your sample, right? And we want to know, is there everything functioning, right? Is their body system working correctly? Are they on medications? Do they have environmental allergies? Is there something that led up to this? What does their environment look like? Are they homeless? Do they have a home? Is the home disheveled or is it tidy? Is there evidence of some kind of substance or chemical that's contributing to the factor today? And then lastly, we want to make sure that we understand whether or not they have some kind of history of psychogenic issues. And are those particular issues that they have, if you understand them, do the symptoms seem to be correlating to that particular illness that they have? So if they are diagnosed and they tell you that they're diagnosed with chronic depression, does today's event look like a product of chronic depression? Now, as we make our way into the secondary assessment, we're looking for signs of an organic cause of this behavior. We want to know, are there vital signs within normal limits? Is there a reason that they would not be mentating appropriately, such as hypoxia, a low sugar, or some kind of other perfusion issue? Again, in this slide, it says that there's tattoos and scars. In reality, the scars that you may be looking for are what we would call cutting scars, where people create a physical manifestation of their mental pain, right? They will create this physical pain sensation to kind of experience it and feel the slight relief and then the healing process from that. But in regards to tattoos, that's not really something that we should be considering as part of the secondary assessment, right? This is purely something that these patients have chosen to do as far as artwork. We are looking for other vital signs such as skin temperature. Are they febrile? Is that a consideration to their mental status? And are they clammy or profusely sweating? Have they anything that shows any kind of head trauma, and that can be swelling or a laceration. We're looking at the pupils. We want to know, are they equal and reactive, or is there an unequal pupil to this and they're not reacting to light appropriately, because the optic nerve is tied directly into the brain, and so this is usually a cue for you if you have something going on. Use your sense of smell. Is there some kind of chemical, be that alcohol or other odor upon that patient, right? We're looking for those subtle cues for things that are going to cause this behavior. You can also look for extremities for needle track marks or something like that. And by that, we're talking about that persistent drug abuse or, something along those lines. And if they have tremors, is that a cause of some kind of drug, or is that a nervous system issue?